Welcome to the deep dive. Today, we're really getting into something important, especially, I think, for anyone studying psychology, the complexities around diagnosing schizophrenia.
Yeah, definitely. We're looking at excerpts from Schizophrenia Diagnosis, Classification and Challenges.
Yeah.
Lots to unpack there.
Absolutely. And our goal here, our sort of mission for this deep dive, is to pull out the really crucial stuff you'll need. Thinking about you as future psychologists.
Right. It's more than just memorizing symptom lists. It's about getting the nuances, the challenges, the real world impact.
Exactly, how this actually plays out. So let's start right at the beginning. What actually is schizophrenia, fundamentally?
Well, at its core, schizophrenia is a chronic, often pretty severe mental disorder. It really impacts how a person thinks, feels, and behaves.
And there's that element of losing touch with reality.
Yes, that's a key characteristic. Experiences like hallucinations, delusions of sort of detachment. And for you as students, some quick facts are good to have in mind. Prevalence is around maybe 1% globally. Typical onset, usually late teens, early 20s, say 16 to 25.
Right.
It hits males and females roughly equally, though how it first shows up can differ a bit. And importantly, it's considered one of the most disabling mental illnesses.
Wow. Okay, that really drives home why getting the diagnosis right is such a big deal. It's clearly not just about, finding a label.
Oh, absolutely not. A correct diagnosis is, well, it's the foundation for effective treatment, for planning care that actually helps someone recover.
And accessing support, too, I imagine.
Exactly. Access to services, support systems, and think about the flip side, getting it wrong. Inappropriate treatments, stigma, massive disruption for the person and their family. It's huge.
Okay, so we see what it is, why accuracy is vital. How do we actually classify it? You mentioned our source talks about two main systems, DSM-5 and ICD-10. What are the key things students need to grasp about the differences?
Right. These are the big two globally. DSM-5 is the U.S. standard, ICD-10 is international from the WHO. Understanding how they differ is, yeah, pretty essential.
So DSM-5 first.
Okay. DSM-5, it's very symptom focused. Critically, you need at least one positive symptom. We'll get into what those are later. And importantly, DSM-5 drops the old subtypes of schizophrenia. It looks at the overall symptom picture. Plus, the symptoms need to be there for at least 6 months.
6 months. Okay. And how does the ICD-10 compare, the international one?
ICD-10 is part of a broader medical classification system, so its approach is a bit different. For schizophrenia, it actually requires at least 2 negative symptoms. Again, we'll define those soon.
Interesting. Okay. 2 negative.
Yeah, and unlike DSM-5, ICD-10 does still include subtypes, 3 main ones, and the time frame is different too, only 1 month of symptoms needed.
1 month versus 6? That's a pretty big difference right there.
Yeah.
And subtypes in ICD-10. Tell us a bit about those.
Sure. So ICD-10 has paranoid hebephrenic, which is also called disorganized and catatonic subtypes.
Okay.
Paranoid is mostly about strong delusions and hallucinations, but often functioning is a bit better preserved compared to others.
Yeah.
Hebephrenic, or disorganized, involves, well, disorganized behavior, speech, kind of flat or inappropriate emotions. The outlook is often considered poorer there.
And catatonic.
Catatonic involves major disturbances in movement. Could be immobility, like staying rigid, or excessive pointless movement. It's actually seen much less often these days, but it's still in the ICD-10 classification.
So you've got these two major systems, DSM and ICD, with different symptom requirements, different time frames, and one has subtypes while the other doesn't. What does this mean practically for diagnosing people who are doing research?
Well, it definitely creates challenges. You could have someone who meets the criteria for schizophrenia under, say, ICD-10, but maybe not quite under DSM-5 or vice versa,
Okay.
which obviously affects who gets diagnosed, what treatment they might access, or even if they qualify for a research study. It makes comparing research across countries, using different systems, quite tricky.
Yeah, I can see that. It highlights the need for everyone studying this to really understand both systems. Okay, let's dig into the symptoms themselves. Positive and negative. What's the difference?
Good question. It's a helpful distinction. Positive symptoms are generally things added to someone's experience, things that aren't typically there.
Like hallucinations.
Exactly. Hallucinations are probably the best known. Sensory experiences without an external cause. Hearing voices is most common, but they can be visual, tactile feeling things, olfactory smells, or even gustatory tastes.
And delusions.
Right, delusions are the other major positive symptom. These are really strong false beliefs that the person holds on to, even with evidence against them.
What kinds of delusions?
Oh, various types. Persecutory, believing you're being targeted or harmed. Grandiose, inflated sense of self-importance or power. Delusions of reference thinking random events are directed at you. Control delusions, feeling like thoughts or actions are controlled by outside forces. And somatic delusions, false beliefs about your body or health.
Those sound incredibly disruptive. So what about negative symptoms then? You said ICD-10 emphasizes those.
Right. Negative symptoms are more about a reduction or absence of typical functions, things that are taken away.
Okay, like what?
A key one is avolition. Basically, a major lack of motivation or drive leads to, maybe not keeping up with hygiene, withdrawing socially, trouble starting or finishing tasks. Another big one is elegia, or poverty of speech. Talking less, taking a long time to respond, maybe speech seems empty or repetitive.
Okay, left outward expression.
Exactly. And it's interesting, for students, ICD-10 clearly calls elegia a negative symptom. DSM-5 sometimes sees similar speech issues as part of disorganized thinking, which kind of falls under the positive symptom umbrella.
So even classifying a specific symptom can differ between the systems.
Yeah, it shows how complex pinning this down can be. Which leads us nicely into the whole issue of reliability and diagnosis.
Right, reliability, basically consistency.
Exactly, consistency. If we're diagnosing, we want it to be reliable. Meaning, ideally, different clinicians looking at the same person should arrive at the same diagnosis. That's inter-rater reliability.
Right.
And the same clinician seeing the same person at different times should also be consistent. That's retest reliability. And the assessment tools themselves should consistently measure what they're supposed to be consistency. Internal consistency.
Makes sense.
Yeah.
Our source mentions a study, Chenot and colleagues. What did that find regarding reliability?
Yes, the Schizophrenia study. That was quite revealing. They basically took a group of patients and applied both DSM-IV, the version before DSM-5, and ICD-10 criteria.
Yeah.
And they found pretty poor agreement between the two systems. The same patients often got different diagnostic outcomes depending on which rulebook was used.
So low inter-rater reliability between the systems.
Precisely. It really highlighted a need back then for, better training on using the criteria consistently and maybe clearer, more unified guidelines to try and get clinicians onto the same page more often.
That definitely flags reliability as a challenge. What about validity? Our source says that's about accuracy. Are we actually diagnosing the right thing?
Yes, validity is arguably even trickier. Are we truly identifying schizophrenia or something else? Several big things mess with validity.
Like what?
Comorbidity is a huge one. That's when someone has more than one disorder at the same time. For instance, Buckley and colleagues found that about 50%, half of people with schizophrenia, also have depression.
Wow, half. That must make it hard to tease things apart.
Absolutely. And then there's symptom overlap. Some symptoms of schizophrenia, like changes in mood or thinking, can look a lot like symptoms of other conditions, say bipolar disorder. Differentiating accurately is tough.
The source also mentions bias, gender and cultural bias.
Yes, these are really critical points for validity. There's evidence suggesting men might be diagnosed more often, potentially because symptoms might present differently in women or be missed. That's gender bias.
And cultural bias.
That's about how behaviors or beliefs that are normal within a specific culture might be misinterpreted by a clinician from a different background as being psychotic symptoms.
Like spiritual experiences.
Exactly, or different ways of expressing distress. If a clinician isn't culturally aware, they might misinterpret things, leading to an inaccurate diagnosis. Big validity issue.
Okay, so reliability and validity are clearly complex.
Yeah.
Our source brought up some key research studies. The Rosenhan study on being sane in insane places, that one's famous. What was the takeaway there?
Oh, Rosenhan. Yeah, a classic. Basically, Rosenhan and some colleagues, all mentally healthy, faked hearing a single word like thud to get into psychiatric hospitals.
And they got in?
Every single one, mostly diagnosed with schizophrenia. And crucially, once they were inside and acting normally, the staff still interpreted their normal behaviors, like taking notes, as symptoms of their supposed illness.
So they couldn't tell they were sane.
Essentially, yes. The study raised massive questions about whether psychiatric diagnoses were valid, whether staff could distinguish sane from insane in that setting. It led to a lot of debate and some reforms.
Definitely makes you think. What other studies did the source highlight? Something about migrants.
Yes. Pinto and colleagues found that Caribbean migrants in the UK had higher rates of schizophrenia diagnosis. Now, the reasons are complex. Could it be diagnostic bias or other factors related to migration stress or genuine differences? It raises important questions for you as future clinicians about diverse populations.
Hmm. And differences between countries.
Right. There was the Copeland study back in the 70s. They gave US and UK psychiatrists the same patient description. The US psychiatrists were way more likely to diagnose schizophrenia than the UK ones, who leaned more towards diagnoses like depression. It showed how diagnostic habits can really differ culturally.
Wow. And racial bias, Escobar's work.
Yes. Escobar pointed out how, particularly with Black patients, clinicians might overinterpret symptoms or view communication styles rooted in cultural mistrust as paranoia, leading to higher rates of schizophrenia diagnosis. Another major challenge to validity.
These studies really paint a picture of how messy diagnosis can be. What's the actual impact of all this? The unreliability, the validity issues in the real world?
The impact is huge. For the person diagnosed, getting it wrong can mean wrong medication, years maybe of ineffective treatment, immense stigma, disruption to life, work, family. It's devastating.
And for the healthcare system.
Well, if diagnoses aren't reliable or valid, how do you plan effective services? How do you research causes and treatments if your study groups aren't accurately defined? It wastes resources and hinders progress.
And society.
It erodes trust in mental health care. It can reinforce inequalities if certain groups are consistently misdiagnosed. It fuels misunderstanding. It matters everywhere.
Given all these challenges, where are things heading? Are there efforts to improve diagnosis?
Oh, definitely. There's a lot of work being done. One trend is towards more dimensional approaches.
Meaning?
Instead of just yes-no categories, thinking about symptoms on a spectrum or continuum. How severe is this particular symptom? It might offer a more nuanced picture.
Okay.
There's also loads of biomarker research looking for biological signs, maybe in brain scans or genetics, that could eventually help support diagnosis, though that's still very much in development.
And addressing the bias issues.
Crucial. More focus on cultural competency training for clinicians, understanding how culture shapes experience and expression, and using standardized interviews, structured assessments to try and make the process more consistent, less reliant on subjective interpretation alone.
So trying to make it more objective and sensitive. What about longer-term goals? Where does the field hope to get?
I think the big hope is for a more integrated approach, pulling together clinical info, psychological testing, maybe those future biomarkers, to get a really holistic view of the individual.
Personalized diagnosis almost.
Exactly. Moving beyond just ticking symptom boxes to understanding the whole person and tailoring treatment to their specific needs and profile. The ultimate goal isn't just diagnosing, it's improving function, improving quality of life.
This has been incredibly insightful. We've covered a lot. Defining schizophrenia, the DSM versus ICD differences, positive and negative symptoms, the really tough issues around reliability and validity backed up by that research.
Yeah, and the impact it all has and where things might be moving.
For our listeners, the psychology students, getting a handle on these complexities is just so foundational. It's not simple, clearly.
Not at all. And remembering that diagnosis is a tool, but it requires critical thinking. You have to consider the person, their context, and the limits of our current systems.
So maybe a final thought for you, our listeners, to take away. Considering just how complex diagnosing schizophrenia is, with all the challenges we've talked about, what ethical responsibilities do you think you will have as future clinicians or researchers? Think about that need for constant learning, for cultural humility, and for always questioning the tools you use. How will you approach diagnosis knowing what you know now? Definitely something to reflect on. Thanks for joining us on this deep dive.